Hello, ladies and gentlemen. I would like to welcome you at our third session. We've already had two dynamic sessions. I hope that the third one will not be less dynamic, but we will touch upon specific solutions for the system, efficiency of healthcare systems. We will be talking about drugs, among others. And I would also like to invite you for tomorrow. Currently, I would like to invite you to hear out two topics regarding prevention, and we have two speakers, Ms. Marta Pawłowska and Professor Marcin Czech, who will tell us a bit more about different topics. So please join me here so that I am not left on my own here. I heard that I look like in a professional TV studio, so please join me in my studio. Marta Pawłowska, expert on health promotion and disease prevention, in particular prevention of obesity and overweight. We will hear her present on the national strategy for reducing obesity and interdisciplinary approach and public-private partnerships benefiting public health. Thank you for this invitation. It is a huge pleasure for me to be able to speak in front of you. I have been dealing with this topic for 20 years, and I think this is sufficient for me to have an idea of the topic. And before the lunch break, we talked about being responsible for our own health. I like a comparison I heard once that in the case of obesity, it is a gun where bullets usually are related to genes. However, it is the society which pulls the trigger, and I do agree with that, and that is what we're going to talk today about. Oh, how big of a phenomenon is obesity? I won't be talking about that. I won't be talking about 3 of 5 people in Poland is overweight, and every 4th is obese. Based on OECD data, we know that in 25 years, because of obesity in Poland, the average lifespan will reduce by around 4 years, which is much more than in other OECD countries. Are we doing something to address this? Well, theoretically, let's have a look at obesity prevention. We have some overarching documents. We have actions taken by local government units or non-governmental organizations, by companies, but still it is not possible to assess their efforts because there is no national strategy, because we don't have intra-departmental cooperation, because we don't have the necessary pathways of cooperation between central administration and local administration. It's not possible because we don't have the measures for assessing the quality. And last but not least, we don't have a long-term perspective system for financing such efforts. In 2022, the institute at the Łazarskiej University have set up an informal partnership towards combating obesity. We did it to promote comprehensive knowledge on the problem of obesity and overweight, and to work long-term on reducing this problem. For 1.5 years, we have been working on a report, the cover of which you can see on this slide. We published it in June 2024, and the essence of this report is specific strategic assumptions which aim at reducing obesity in Poland. We discussed it at a conference in Warsaw in June, which was participated by representatives of 7 ministries, many MPs, representatives of the academia, of companies, and of social institutions. And now I would like to tell you a few words about that strategy. The objective of this strategy is to set out a roadmap for the decades to come, so that we bring together key decision makers and stakeholders. What we want to do and what we have been doing for some time is building a national intra-departmental network which will set out the cooperation pathways between administration, between the academia, the society, and companies. We believe that this type of cooperation will help reduce the obesity rates in Poland. Obesity as a health, social, and economic issue. What is of key importance to us is that we look at prevention and diagnostics separately. We treat them equally, but we do not put them into one basket, so to speak. When looking at the decades to come, as it is a long-term initiative, what we see with obesity among children and young adults, we claim that in the next decade, in our prevention, we should focus on obesity in young people. And when it comes to diagnostics and secondary prevention, all target groups should be addressed. A first important slide where I would like to point your attention to is our systemic approach to obesity. For several years now, there has been a systemic approach. So this whole system approach to obesity, it's been there in the network, but even when translated to Polish, somehow it has been difficult to grasp in the Polish setting. This system is evidence-based in many countries, like in France, Finland, the Netherlands, US, UK, and some other countries. It's there. It's a system which integrates actions at a national level, tailored to local needs. When you talk to organizers, and I've been working quite closely to the Spanish and the French who are implementing this, there are two main prerequisites. First of all, overall supervision. It needs to be a governmental strategy. It cannot be just the owner of the process cannot be just the ministry. It needs to be entire government. The strategy which has been adopted in June 2022. The owner of that is a vice minister. We need someone higher up the ladder to be in charge of this program. And the second prerequisite is a grassroots approach. So involving local decision members and empowering people and increasing the obligations and the responsibility of the local governments. Another important slide is the social ecosystem Stop Obesity. This shows the life of all of us. This shows 8 aspects which are interconnected, which impact on how we on our health and on our possible obesity. Reduction of obesity should be included in that. Those aspects include family, education, health, sport and rest, culture and media, business and work, and infrastructures. All interventions which we have in the strategy, some of which I will present to you today, are based on encompassing as many of those aspects in reducing obesity. This is important also. What is also important in this model is that we are talking about reducing or preventing obesity throughout the entire lifespan, not just in primary school or high school. Research shows we have to look at this problem long term. We're talking about education since conception until late age, until the end of our lives. Now, also the focus between different ministries, different departments. So, cooperation on the level of institutions, the academia, social representatives, and companies. We are convinced that on each of those levels, we should have various actions in forms which would address reducing obesity. As part of this strategy, we suggest appointing teams that are combining all those representatives, which would work long-term on that. And we are currently implementing this strategy. On the 14th of November, we will hold a first so-called social round table in a hybrid mode, so online and on-site, which will bring together, among others, social community organizations. In the first quarter of next year, we will launch works on the level of the academia and of institutions, because we claim that at each of these levels, the actions need to be in-depth, need to be specific, and need to be linked together. Here you can see this map that we created for the purpose of the mid-sector dialogue conference. We suggested various organizations which, in our opinion, create this map. Institutions which are responsible for our health and also for reducing obesity. This is not even everyone. These are the ones which we at that point found to be pertinent. Now we know that more organizations are approaching us, so we will increase the number of institutions on this slide. But this is how we see reducing obesity. From the level of institutions, we invited 14 different ministries. Of that, 7 indeed did participate. I had a call from an assistant from the Ministry of Culture, and she said, oh, there's been a mistake. We are in the Ministry of Culture, and you invited us to talk about obesity. But tell me, is it not you who organize thousands of various events for young children where you promote junk food instead of healthy food? Are you not related to culture? Well, yes, that's us. So indeed, you are the target group here. So we had dozens of such conversations, which enlightened people. I talked, for example, to the Minister of Agriculture. Well, he said only we are responsible only for the quality of food. Well, not necessarily, and I showed him that their role here is larger. And the Vice Minister of Agriculture mentioned, he mentioned in a conference that we will be promoting fighting with obesity among farmers because we have the best access to them. So this is the change in the approach which we need. This is an overview of the various values. So health as the main aspect of all actions. Prevention since the beginning. Educating and activating our families. Eliminating inequalities. Studies show that we do have geographic inequalities, economic inequalities, inequalities between genders, preventing health, protecting health rights to protect health, evaluating existing actions, and adjusting efforts. We prepared 2 strategic directions for our strategy. Like I said, one tier is prevention, the second one is diagnostics and treatment. So we worked out various proposals. This is not something that we just came up with while drinking coffee. Over the course of 1 year, we performed a very in-depth review of what other countries do. We carried out a benchmarking analysis for 13 different countries where we used 18 different criteria. We also looked at our Polish situation, what we do and what is missing. And using all that, we created a matrix of proposals, which is a part of our strategy. As an example, The first strategic direction, so alimentation, food and eating habits. For example, ensuring access to drinking water. The Spanish have shown that school-age children drink soft drinks because they don't have access to free of charge water. When free of charge drinking water was introduced, children tend to drink less soft drinks. This applies to both children in schools as also children in various kindergarten settings. So we postulate to ensure free of charge access to drinking water. We also postulate co-funding to co-funding of healthy food to less well-off families. We also suggest treating different taxes on junk food. Lancet for the first time used the phrase health-harming industries. Now, this is already existing in the debate. We have products which clearly, and we have data to support that, which have a negative impact on obesity. When it comes to physical activity and sport, we postulate, for example, supporting changes in spatial policy, which would foster activity and physical activity and sport. Recently, I talked to my colleague who works in a large association of employers in France, and they also deal with preventing obesity. And he says, Marta, what we do now is we teach people to take the stairs, because they did some studies which indicate that indeed we stopped taking the stairs, especially when at work. In some facilities, it is even forbidden. They are only used as an evacuation emergency route. We have been trained to take the lift. And now in France, people are promoting to taking the stairs. They have been making this space of the staircase more friendly. They, for example, promote spending time on the staircases. We used to take the stairs. Now we are predominantly taking the lift. We stopped having the natural reaction to take the stairs. So we are talking about serious interventions, and I'm talking about water and stairs, but this is about the small steps. We are also postulating ensuring free access to public sport facilities for children aged up to 18. This is a solution present in other countries. Also, supporting electronic solutions which foster physical activity. We also talk about supporting the work-life balance and supporting families in crisis and fostering familial relations. More about prevention, we, for example, postulate to talk about combating stigmatization. So no stigma. We don't want to have a network of, we are against a network of healthy schools. What about the rest of the schools? We want standards of healthy educational institutions to apply to all schools, all preschools. When it comes to diagnostics and treating, we are postulating improving the efficiency of diagnostics and monitoring of obesity, increasing the availability of support for people with obesity. Also, increasing the availability of drug and non-drug technologies in treatment of obesity. As part of our strategy, we also came up with 5 mechanisms which need to be present for this strategy to be actually effective. It's research and innovation, it's communication and raising awareness, it's financing, it's ensuring synergy as part of local policies and synergy as part of national programs. I analyzed 30 different legal acts, strategies, national policies, and I searched for the word obesity, combating obesity. Apart from some medical-related programs, there are no specifics. But if it's supposed to be meaningful, if this strategy is supposed to be systemic, obesity should be specifically embedded in such strategies like the National Strategy of Regional Development or some other documents related to the media. If it's missing there, then we will continue to focus on the silos approach. Because right now, combating obesity is not an overarching activity. Now, monitoring efficiency. We have developed the factors for monitoring the efficiency, and we came up with structure and process factors, and those which are common for both directions. Now we have 60 different indicators, both for prevention and for diagnostics and treatment. I have 15 seconds left, so I would refer you to the report for more details, but I would like to tell you about the result indicators. So, for example, we mention social discrepancies. We also mention differences between different sexes or genders with people who are obese. We talk about sedentary life in specific groups, about the consumption of selected foodstuffs, about the breastfeeding period by young mothers, or the absentee days caused by obesity, or absenteeism caused, for example, by a deterioration to the knee joints caused by obesity. I am aware of the time. I had a quick run through my slides. I would like to thank you for your attention. I would like to invite you to join our partnership. Please work with us. I want you to find yourself on the map that I presented previously. And I know that we will be approaching a lot of you, because I know that if we manage to unite our efforts in this strategy, we will also be able to combat problems with the mental health in a similar manner. But that's a song of the future. Thank you so much.
We will have a question-answer session after two presentations. We've talked about obesity. Now let us move to the other preventative measures, immunization programs and their effectiveness. The President of the Polish Society of Pharmacoeconomy, Marcin Czech, Professor. Thank you very much for giving me the floor. It's always a privilege and honor to talk to you in such a beautiful city as Krakow. On the first slide, I used the AI to generate the picture. That's how the artificial intelligence sees the efficiency of the immunization system. Look at the baby, how it is said. Polaska means Poland for artificial intelligence. It's below. Actually, the artificial intelligence was unable to recognize Poland. Maybe we are not promoted enough. I will talk about protective immunization, and I share the view of the previous speaker. I actually take the stairs here. I use the lift because I had the luggage, and even if there is a no enter sign on the door at my floor, I still use the stairs. And I know that some doors are blocked to the staircases, but still I do use the stairs. Here you see the outline of my presentation. I will first talk to you about the benefits of the prevention, then the access to immunization in Poland, and I will move to the financing of protective vaccines and the decision-making processes regarding the choice of vaccines. I will analyze each stage of this decision-making process, and I will end with the disinformation. in any discussion on efficiency, we also need to mention the reliable sources of information. Let's start with the definition to be on the same page. According to the Dictionary of Polish Language, efficient means sufficient, yielding good crops, providing benefits or effects proportionate to the work or effort, something in big quantities. And efficiency means the production divided by outlays in order to get the best results. Now, some words about the story of contagious diseases, and actually COVID was a sort of a wake-up call for us in Poland. It took more than 200,000 deaths. Here you see the pictures which were not painted by artificial intelligence, and you have the statistics of the victims of specific plagues across history. And everybody is concerned, even those who eat healthy and exercise. What are the benefits of the immunization of the population? Well, they're of social level, medical level, they have impact on public health and on economy. Ladies and gentlemen, let's just have a look at the efficiency of our immunization program. Numbers are really telling, and they're not quite optimistic. We can wait 12, 15, 20 years for a decision, for instance, regarding combined vaccines, and we're still waiting for the decision. And as to the access to immunization, we are really not in the top. How is it financed? We have a public market with mandatory vaccines and a private market with recommended immunization. So both public and private payers are to a large extent participating. But this is not a mixed approach. Let's say that if the parent buys a combined vaccine, the parent will cover the cost. The money comes either from the National Health Fund, from the regional health programs, and the rest is paid out of the pocket by the patient. That would be the financing system. And now let me move to the ecosystem of immunization. The slide shows that the Ministry of Health, represented by this nice building just in the middle, so the Ministry of Health is a decision maker, but there is an expert board, NITAG, then there is the National Health Fund, the HTH technology, the Chief Sanitary Inspectorate, where there are many stakeholders involved in the decision making. It's really complicated. Myself, I was a part of the management at the Ministry of Health, and actually I took a functional approach to vaccines as medicinal products. And my functional approach was based on this table with different types of reimbursements. Reimbursements at pharmacies, drug program, health prevention programs, immunization programs, or regional programs. Well, plenty of possibilities. And here again, I asked Google to provide me with the most complicated chart. And that was exactly the chart I used to explain how to make a decision at the Ministry of Health. But with this decision-making chart, you are unable to be decisive. And I do remember my meeting with the new Chief Sanitary Inspector, a man of charisma, someone open to conversation, but actually he said, well, actually I cannot do anything. There are different people involved. Well, nothing has changed. So how to get public funding for immunization in Poland? The decision-making process is extremely complex. You have to need a lot of recommendations from EPI Sanitary Council, NITAC recommendation, HTA opinion. We have the lowest spending on immunization in the EU. It's €3 per citizen on immunization. That's the lowest level in the EU. Then you need to change the timeline of vaccinations. That would be the central level, or you can move down to the regional level. You need to make a coalition, sort of an immunization coalition. Again, the HTA agency has to issue an opinion. Again, the validation of budget. Again, this is not a simple decision-making flow. For me, this is the easiest way. At least you have deadlines here, including deadlines for appeal. Just think about vaccines as of medicinal products. So the negotiations, Transparency Council, the involvement of Economic Committee, and then finally the decision. The last vaccines to be reimbursed from public budget, for instance, for shingles, went through that path. However, the co-payment there is quite high, but I will come back to that later. And I think that for flu, we are ready to take a similar approach, and that could be an interesting model. Health policy programs now. They are about important epidemiological developments. At least that's the requirement. Or health programs targeted at specific groups, or implementing specific medical procedures and prevention measures. Such programs may be implemented either by respective ministries or by local government units. That is why we have a national program for combating cancer and a national program for the development of transplant medicine, and that's how we came up with the cervical cancer vaccination, and Scots introduced such immunization program 10 years ago, and they have no cases of cervical cancer. We have 10,000 deaths. 10,000 deaths per year. That's a small cemetery already. But this, the number of these health programs has been decreasing. And actually, our Supreme Audit Council said that these health programs increase disparities between regions. And it's really hard to refute this argument. If you live in a wealthy region, you have better access to immunization than people who live in less affluent places. Well, ladies and gentlemen, what are the pillars of efficient decision-making process in immunization? Well, it's timeliness. Instead of having 15 or 12 years, be short. Inclusivity. So the program should include all stakeholders who wish to become involved in the process and in the decision. Consistency in using the method of assessment and transparency. And this is not a rediscovery of the wheel or my rediscovery. These are international standards developed for all 27 EU member states. This was done at some point. As you know, or maybe you know, Poland was not actually the leader of the classification. This decision-making process spans over 4 stages. First, it's about building strategy based on epidemiological needs. Then, triggering the process and assessment of available technologies and building recommendations. Third, assessment and allocation of resources and decision-making in line with the strategy and recommendations of the expert team. And fourthly, assessment and improvements to the immunization programs. Just have a look. This part of the room will have a better view. I'm sorry. First stage. So, horizon scanning analysis, early advice, and registration of the vaccine. Second, initiation of the assessment recommendation of the advisory body, then HTA assessment. Third, assessment of resources, decision on financing, procurement, and then evaluation. And what we did, we tried to do that. We formed such expert body, expert group. You see on the slide some very familiar faces, people involved for many years. There is, for instance, the deputy president of the National Health Fund. He has always said that we have 400,000 zlotys in the budget for vaccination, and we spent 800,000 for vaccination each year. But also pharmaceutical experts, vaccinologists, scientists. So in this task force, we organized a number of sessions, and this yielded a publication. You see the title on the slide. The basic question was how to strengthen the assessment and decision-making procedure in the pre-registration stage, in the assessment stage as well. I don't know if you know that the advisory body to the HTA agency, and the members of this body are remunerated. This is a transparency council, and it is remunerated except for sessions and assessments regarding vaccinations. That is why we decided to suggest that in the case of vaccination, it should be better formalized. If you want a reimbursement of the drug, this is triggered by the marketing authorization holder. For vaccines, you don't have the same path. So the inclusivity was not good. I see that the time is pressing us, so I will just skip some parts. The NITAC should have a better legal legitimacy. The legislation provides for the creation of NITAC, but it's not its powers are not fully defined. And there is no secretariat or any auxiliary staff. The scope of powers of NITAC should cover a pre- and post-registration actions, including horizon scanning, plus the assessment of vaccinations, together with the outcomes. It's not easy because it spans over time. The assessment includes indirect costs as well. I don't have to explain to you the details of such assessments, but anyway. The HTA assessment, the budget should be truly realistic. And we actually should spend more on immunizations, and we should do more to remove any obstacles. Resource assessment. We simply need to define what resources we have at hand and how they should be used. Procurement process. Well, I have plenty of stories, believe me, of the payer or the ministry simply asks the manufacturer saying, we have a pertussis epidemic and we need vaccinations. And the manufacturer says, but listen, but we need to plan, like in 2 years. We need to plan, we need to produce. You know what I mean. This is a sort of a long-term planning, long-term horizon. And it would be good to have a national immunization strategy. Ladies and gentlemen, I don't want to say that only Poland has immunization challenges. Europe has been taking steps to prevent contagious diseases. It's easy to close land borders, but viruses and bacteria do not know any borders. Here on this slide you see the famous WHO pyramid with the immunization at the very foundation to be included at every stage of a human life. So this is a whole life venture. Immunization is not only about children, it's also about pregnant women. We secure women and the baby. Then people with chronic diseases, frequent travelers, or silver population with a much more weakened immunity systems. For these groups, we should not have any logistic obstacles. You know, first you go to the primary care and they give you the prescription. They go to the with the prescription to the pharmacy. The pharmacy says, okay, but we cannot vaccinate. So comes back to the family doctor who refuses to vaccinate them, and so on and so forth. And my mother, 85 years old, she asks me, what kind of vaccination do I need? I said, shingles and flus. And she says, I spent 350 zlotys because you told me that it's reimbursed. Yes, but only in half. So as you can see, there are plenty of obstacles, logistic obstacles, economic obstacles. Otherwise, we will have 5% vaccination rate for flu. Coming to an end, I would like to say that the whole sequence should be organized, but the financing should be well thought. I had a conversation with a taxi driver in Krakow. He asks me about my stay, and he asked me whether he should have his granddaughter vaccinated against herpes. So, this is a Christina. Christina, a candidate from A9 constituency to the Senate. WFI are killers. Have a look at what she says. Jerzy Zięba is a savior of the people. She is interested in Nibiru planet, New World Order, Illuminati, and the population by Bill Gates. I don't know if you know, there is a special congress organized in the Silesia region titled Something the Doctor Would Never Tell You. That's the title. And they would tell you that with every vaccine, the child would get also his or her portion of poison. I think that the request was filed to the prosecutor's office, and they actually first refused to investigate the case. Right now, after the new request, they launched the proceedings. So, it's our senator on the left, and on the right we have Kirsten Weldon saying that there is no COVID-19, calling people who vaccinated as idiots. And then she got the coronavirus and didn't change her mind. She died. And the friends of her were threatening the hospital and accusing the hospital of her death. Just have a look at the sources on the immunization: CDC, WHO, the Chief of Sanitary Inspectorate, the Chief Pharmaceutical Inspectorate. And I know that the Polish Ministry of Health is in conversation with the Ministry of Education to run a awareness-raising campaign. And the same will be done together with the Ministry of Labour, Family and Social Policy. And there are also books about immunization programs and research papers as well. So I just look at the clock and it's 0. So it's good. Then it's basically 0 and there is no delay. It's always 0, nothing changes. But when I look at my clock and I see 0, I know that I have to end. So just let me leave you with my most famous cartoon on the left and the mural in Seychelles. That was my photo on the right. People can be serious about immunization. Believe me, that could be more serious than those on the picture. Thank you very much, and I do hope you will have questions. Thank you.
Thank you. So in this part, we now have time for a Q&A session. I do have my own questions, so we'll see if we have the time for them. But what about questions from the audience? Oh yeah, we do have those as well. A question to Marta Pawłowska. I would like to thank you for this incredibly interesting presentation. I would like to ask you why in those models in combating obesity there are no commercial health determinants, because it's quite a comprehensive strategy, but research has shown, and WHO has been striving towards indicating that the main driver of obesity among young people and adults is the food industry. Please have noticed that we didn't blame anyone. We didn't write who is to blame for obesity, but in those specific elements, all those aspects are encompassed. When we're talking about protecting consumer rights, in particular children in contact with the food industry, this is something we took into consideration. So the health harming mentioned by Lancet, this is there in place. So this is something we will be developing even further. In this short presentation, I didn't get the chance to present everything in detail. Furthermore, it is not our intention to go against any specific system. We don't want to criticize anyone. No one is forcing our children or our parents to choose specific programs. Here, I wouldn't understand with this. I'd say we are being forced with some. If I may counter that statement, I would like to say that advertisements targeting children literally puts some products into our baskets. Children screaming for candy, waiting for the till, and those products being positioned specifically to be there while we queue. And those queues are also created artificially so that we have the time for the children to demand it. American research shows that some of the capital which used to deal with the tobacco industry moved to the food industry and uses the same strategies of hooking consumers up, making them dependent. And I understand that we shouldn't be maybe criticizing the people who are to blame, but failing to notice them. I wouldn't agree that we failed to acknowledge this, but one of the main errors, in my opinion, in communicating about obesity with the society is, as it can be said, when it comes to diet, just eat less. It's not just about that. Professor Bednarczuk, an expert on obesity and endocrinology, he says there's nothing called just simple obesity. It's always more complex. So what I would like to suggest is maybe it would be worth to indicate, maybe in a neutral way, but indicate the role of the food industry. But we do that. I started my presentation that obesity is a gun and the bullets are mostly genes, but it's the society who pulls the trigger. We do talk about it. We cannot always present everything in 20 minutes. Let me reiterate, behavioral economy is something which encompasses various aspects, also the positive ones, not just the negativities. And the food industry is working in line with the specific legal national provisions. Few people know about obesogenic factors. This is not something many people know. This is a very complex aspect. That's why we created this ecosystem model, because this is something which affects various aspects of our lives. It's not just grocery stores, it's about the environment surrounding us. We have research proving that chronic stress and polluted environments increase the risk of obesity in children up to 8 years, increases by 5%. Just those factors. So segregating those factors and implementing systemic efforts is something we will be doing over many years. We will be addressing those aspects. We will be talking about communicating with children, addressing children. It's not about advertisements targeting children. It's a broader subject. We will be talking about it, but we want to do it professionally, in a long-term, reasonable manner, so that we can reach all stakeholder groups. Thank you for this remark. I will keep that in mind. I can tell that this will be one of the main aspects of our actions. But the industry is not afraid of these talks. We are currently in conversations with various institutions which bring together food product manufacturers. And after some confusion at first, we can see that they are willing to be in dialogue with us. So I do believe in this dialogue. If I may also comment on that, using this analogy to the metaphor of the gun and the trigger pulling, our country fortunately started addressing this, for example, by way of introducing the so-called sugar tax. We should do more things like that. I think that the WHO data and other data indicates that we know that manufacturers, I will not name who, but a big manufacturer of soft drinks, regulates adjusts the amount of sugar in their beverages depending on whether a sugar tax is existing in a different country or not. But this is the strength of the state, strength of the business side. I know some of the issues are delicate, but I think that for the general health, public health, this is particularly important, because in the Institute of Mother and Child, where I work, we carry out research on the body mass of children and young adults. We are on the the dynamics of the growth in Poland is the worst in the entire set of European countries. We are facing an epidemic of diabetes. Oh, we do have a very enthusiastic Q&A session right now. Grzegorz Marek, I would like to ask you about how you see one aspect, a systemic aspect maybe, regarding intra-institutional cooperation. I'm looking at this from the perspective of mental health. So an area where on the one hand we know that the costs of sick leaves for the system are high because of absenteeism, and on the other hand it's a different line in the Excel file than the issue of contracting services. So if someone needs assistance, they get an appointment after 1.5 years. So the waiting time is horrendous on average. It's like 1.5 months. So we're talking about early actions and prevention. I'm just wondering, from the perspective of the system, to what extent some aspects are not seen by the system. For example, troubles caused by obesity will have a general impact on the health, but it's not an urgent problem for many people. It is a if you address obesity after 20 years, the cost will be much higher, but it's not considered an urgent problem. Also, for example, the case of the the cost of flu vaccinations are not high. Last year, I had some bad luck. I couldn't get vaccinated for influenza for a month. It took me 4 or 5 visits to get a flu vaccination. I wanted to pay for it, but it was not possible. Given the costs of flu cost absenteeism, we should be focusing on such interventions. You should simply get a shot easily. Those costs should be just covered by the system. I'm not sure whether it's the question of different decision makers, or maybe it's the reason why we lack someone who has an overall view. So we got a lot of questions here. You are touching upon key issues related to investing in public health. Unfortunately, the country is managed in a silo system. So we have specific funds in the National Health Fund, and no one looks at it comprehensively, that if the social insurance institution would have some savings, this would be beneficial for the whole country. So we lack a more comprehensive view on the matter. We are trying to change that approach, but we have to keep in mind that savings is something that is generated over time. For example, in the case of obesity management, in the case of mental health. Another thing is that building value. I think that I have to say that both me and Marcin, for like 20, we have 20 years of experience with addressing HTA. We know that it's a long-term perspective that values. So what does a value mean? This is problematic that in the end it always comes down to finances. Some health is difficult to measure. It's called sometimes a quasi-value. So we need a very mature system and a lot of political maturity to be bold enough to take certain decisions, to take a wise approach to financial management. So that's from the bird's eye view. I could be answering a question for a week. That's how complex your questions were. When it comes to indirect costs, something we've been talking for a quarter of a century right now, about the silo-like approach of the state and the different ministries who should be dealing with it and are not. From the perspective of a person who used to work in the Ministry of Health, I can say that the ministries do not cooperate, do not work together. There should be some overarching minister regarding public health. There should be someone who should have a strong political standing and should be wise and neutral. You're laughing, but this is not a stupid idea, because otherwise we will never be able to take a better approach. It's impossible to say how we could, very shortly, how we could get out of this situation, but this is a very complex question. I think that as of now we are headed in the right direction, but we are doing it too slow. Why is the direction correct? Because we are talking about the right things. We are taking into account the need for the right resources. We are talking about we need to retain doctors in the country. We need to secure good healthcare professionals in specific areas. These are elements which will build our strength, also our economic strength, because an obese society today will tomorrow be will be performing poorly on the job market. So it's just skimming on the surface. I'm also adopting a bird's eye view. So the obesity reduction strategy in Spain in 2020, introduced in 2022, it's something that encompasses 15 different ministries. Each ministry has specific tasks, specific priorities, and a timeline, and a quota that needs to be achieved. Apart from the ministry, we have 15 largest academic associations, 24 NGOs, and 37 business associations. The Spanish say that if we manage to succeed with this strategy, we will do the same for mental health, because they combine the issues of obesity reduction and mental health security. And now to the tax, to the sugar tax. Soon, the Supreme Audit Institution will tell us how effective the sugar tax was. I know one piece of data. Can you please tell me? Did have. Apparently he said that it's not that effective, as we'd like to. That means whether the money, the question is whether money from the tax will be spent, from the sugar tax, will be spent on public health prevention. Apparently, it will not be. So we should go to take our lessons from Spain. And it's difficult to maybe watch your diet in Spain.
Transparency Council, Roman Unique. Congratulations. I've got a question to the professor. You've shown some factors which have been reducing our vaccination rate. Actually, in the past, we had doctors who encouraged vaccinations. Today, there are doctors who issue certifications that the child cannot be vaccinated because of the autoimmunology disease. What to do about it? How to handle the case? I think that the chief medical council should act. Maybe they should have a special unit to educate and correct softly the approach of such doctors. I imagine that there may be some counter-indications to immunization. If there are some evident counter-indications, they should be protected, but the other ones should be vaccinated. And I'm not going to list particular circumstances of such severe counter-indications. But it's not about the faith of individual doctors, which goes against the grain of the evidence-based medicine. This is not something ethical. At least the medical organizations should respond, write to such a doctor, ask for explanation, and if it doesn't work, escalate, including criminal liability. Fortunately, we have quite a strong medical professional organization. They have tools to act. Mirosław Jasiński. I'm the first line doctor, pediatrician and neurologist. I know that patients should be at the very heart of the medicine of tomorrow. I know that. But what are the legal tools to be used when parents simply refuse to vaccinate their children. There are more and more of them. What are you going to do? And this is something I see in my everyday work. There are more and more parents who refuse to vaccinate their children. And this is my question to you, Professor. How to counteract or how to change that approach? Indeed, the medical professional organizations have issued some decisions to punish doctors who are anti-vaxxers. That's true. But practically speaking, what to do? How to go about it? Well, my own option or solution would be the same. But I admit I am naive. You simply need to educate and raise awareness. And I can give you the proof that this is effective. The Scandinavian countries, their vaccination is not mandatory, but still the vaccination rates are extremely high. So we can take a different way and still be aware. And then take Australia. Their parents can refuse to vaccinate the child who is healthy, but once the child gets the disease, because the child has not been immunized, parents will cover the expenses of the child's treatment. The sanitary inspector will promise to use such tool, especially that we will have the e-vaccination sheet. So with that, you will have more possibility to follow up and take consequences. I have some micro-scale experiences. During the COVID pandemic, I was in charge of the vaccination at the Institute of the Mother and the Child. Our vaccination rate was 97%. There were some who had counterindications, so finally we ended with 93%. And it's not about virus mutation, the efficiency of the vaccine, and so on and so forth. Nobody died, and only one person was hospitalized because of COVID, thanks to vaccinations. And we did some groundwork. Well, we simply explained things of RNA from animals. Is it going to mix with my RNA? Am I going to be contagious for my mother? My mother should I have her vaccinated as well? These types of conversation. And then we had some hardliners who absolutely refused to get vaccinated, and they were fired by the head of the institute. Well, critical thinking is a key. Medicine is not about faith. Medicine is about a critical analysis of medical evidence, and we are flooded by information on the internet. You just mentioned, Marcin, that you had conversations with people who were not that willing to get vaccinations. So, just talk to people. Don't forget that there will be always some people who will be against vaccinations. The question is what to do to stop the growth of that group. There is no such society where with 100% vaccination rate. I am concerned because the number of anti-vaxxers is growing, and the narrative includes the risk of autism. It's a huge damage to the vaccination rate among children. Maybe we should explain why autism. Well, the narrative says that vaccination causes autism at the age of 1 or 1.5. So counteract such argument by saying just get him vaccinated at the age of 2. And compare side effects or complications after any contagious disease, like after measles. People stop to forget about the consequences of contagious diseases, or like polio. There is no polio anymore. People would say, why to get a vaccination? Because before, such diseases were much more socially visible. People were more afraid and would get vaccinated. Right now, we really have an issue of public education, talking about counterindications, consequences of contagious diseases. And doctors are aware, just don't be afraid. It's better to vaccinate some people than not vaccinate anyone. Yes, you need to be truthful and accurate. And it's not about faith, it's about science and evidence-based medicine. Parents can ask you, okay, the complications cannot be excluded at 100%. Every time there is some cost and benefit analysis, because you may have a myocarditis, or the child may get another heart disease, or get a candidate and become a candidate for transplant, or get a pneumonia. You may get the allergy, and so on and so forth. I will quote those types of side effects, and people are really open to these arguments, and they would agree, and anyway they would get vaccinated. It's not that I'm successful everywhere, but I had anti-vaxxers neighbors, and they have 5 children, and 3 children got vaccinations, and then they decided not to vaccinate the 2 younger ones. Then the COVID happened, and they got scared. And the doctor said, but listen, we have no registration for those children. So that was a major difficulty, logistic difficulty, and the doctor was at fault because simply it was impossible for them to vaccinate their children. And now when they emigrated to the States, they have a dilemma again. So just look around, find tested and meaningful solutions. Magda mentioned polio, and polio is back. In Ukraine, we have reports of polio cases. Everywhere where you have armed conflicts, there would be cases of polio. And the WHO has failed in achieving the goal of 0 polio cases. I'm involved in the elaboration of new immunization guidelines. Evidence-based decision is a methodology used, and you use it to assess patients' preferences and level of acceptance and uptake. If you have a severe disease and a higher risk of shingles, for instance, because the first risk will increase a different risk. So every time you need an individual assessment, and that is why you need conversation, you need to touch upon the costs and benefits of vaccinations. I don't know if Poles would accept any vaccination being imposed from the top. Anyway, thank you very much. There are plenty of topics, and now I'll invite you to the second part because I would like to stick to the time. Thank you very much. Yeah, I won't go. I just got stuck here. Let us move to the second part. We only have 40 minutes. Now let me move to the next speaker, our guest from Czechia. I like Czech people. This is a joyful nation, especially that their statistics, health statistics are great. Martin Kolek is one of the author of solutions for rare diseases, and this solution, Czech solution, is for us an example of novel approach to the reimbursement of drugs for rare diseases.
Okay, so I think that I will make it a bit faster because we have like 20 minutes delay, but I think it's okay. We still can manage. I want to take a pointer. Should I stand up? Or
you can go.
Yeah, so I will stand up, it's maybe more polite for you. So it's a great pleasure to be here. I came back like after 5 years, I think, so it's great to see you again. I'll go to the
you have to, oh.
Sorry.
You have to go to camera.
Sure. So today I would like to show you an example of the new orphan pathway we have in the Czech Republic, which is now valid for almost 3 years. We are now taking some steps to change it a little bit. And I think yesterday it was passed by the Senate, and this month it should be already voted for in the Parliament. So briefly, overview of our reimbursement system, how drugs come to the market, how they are being reimbursed. Before this orphan pathway, which was introduced in 2022, there were 4 possibilities how the drugs could be reimbursed. First, and the most used ones, was the permanent reimbursement, and this process was established in 2007, so it's a pretty old process and it's well established, and it's a bit rigid for the orphan pathways. The other option, which was used very much in the past time, is the individual reimbursement. And basically doctors have to ask for the reimbursement for each patient, so there is a lot of administration, and then the outcome is not predictable, because then the payers decide if they fund it or not. Then there is a pathway for highly innovative medicinal products, where you have to fulfill some criteria like 20% prolongation of overall survival or 30% of improvement of some parameter which has influence on the quality of life. And this process was chosen also in many times, also for orphans. And the last part is for advanced therapy, or if it is hospital use only, then there is basically no assessment, and the hospitals just use the drug or any medical intervention, and then it covers it from its fund, from its money they get from payers. Since 2022, we already experienced 43 cases, which is quite a lot of number in the 3 years for orphan drugs, and it is approximately 15 each year. And out of this, there were only 2 negative decisions, and 17 positive, and 24 are still ongoing. And the main advantage of the system was that it should be a fast way, but I will show you in the end that it's not that fast as expected. So, what are the conditions which make you eligible to go this way? It's that there has to be public interest, so there has to be a need for treatment. You have to sustain the financial predictions or financial possibilities of the healthcare system, and you need to ensure the quality of the care. And the second condition is only you have to have the orphan IMA designation. And then this submission can be done by the payers or the marketing authorization holder. We already have one case when payers ask for reimbursement, and the marketing authorization holder was not very satisfied with this. So what payers need to submit, it's quite easy. They just say what therapeutic indication it is, what is the expected results, and why the pharmacotherapy is needed. They suggest the level of reimbursement, they suggest the proposed reimbursement conditions in the indication, and they have to pay the authority, which is SÚKL in our case, for taking assessment of this procedure. On top of that, the marketing authorization holders need to present the results in clinical trials, including the dosage schemes. They have to present cost effectiveness, and here there is a big innovative feature in the orphan pathway, which is the societal perspective. What was good that in the same time as this was valid from the 2022, the Czech Health Economic Society was working on the guidelines, how to calculate the societal perspective. So this was quite good timing that we had the methodology also to how to do that. Then there is a list of EU countries with price, budget impact analysis, and if there are any preliminary risk sharing agreements, so it should just to be, or it should be presented. We assess more criteria than just price or budget impact and effectiveness. This is new for the orphan pathway, and the new things are the brown ones. Yeah, you have to assess therapeutic efficacy, safety, severity of disease, substitutability, or if there are any drugs, basically unmet need in the area. You have to present or assess societal perspective, both like from the governmental one and from the societal perspective. You have to show that it improves patients' quality of life, and you also have to ensure that the network of healthcare providers can cover all needed patients in the country. This is also a new feature. And you have to be recommended in the guidelines. You also assess reimbursement conditions, and you also assess the risk-sharing schemes possibly dealt with payers. You assess the cost effectiveness, but the result is not taken into account, and also you assess budget impact. Yeah, maybe to say that there is no specific framework for this multi-criteria decision. The assessment is only done during our meeting, it's not public, so the transparency is a question. The orphan committee was created. It has 8 members. They are appointed for 3 years, and they are equally represented by Ministry of Health, payers, professional medical societies, this means the KOLs, and patient organizations. This is also a new feature which was not seen before. What is interesting, that the members of the committee should not have any conflict of interest. So basically, if it is, for example, oncology drug, there can't be any oncologists in the committee, and also there can't be any patient, oncologic patient, which could benefit maybe from granting the reimbursement. So it's separated. But you know that it's very difficult to estimate the conflict of interest, and when it's not public, the hearing, then it's difficult to estimate where it is true. We had this system also for normal drugs. Before 2006, there was also a committee which was accepting or deciding on whether the drug will be reimbursed or not, and it was not a nice time. The meeting of the orphan committee is oral, and basically what the authority does, it gets all the documents which are in the procedure, makes the assessment, and then sends it to this orphan committee. If there is anything new after the SUKL assesses the documents, it's not taken into account. And firstly, there is a first hearing including SUKL and including also the members or participants from marketing authorization holder. And then after that, the committee decides after closed doors. All the members are bound by confidentiality, so you cannot speak about that or you cannot ask for any opinion. And basically, the result is 3, 4, 5 pages of text assessing the criteria I showed you in the previous slides. And the result is, it's positive, it's negative, or they can propose, for example, a lower level of reimbursement, or they can propose maybe narrower indication text, for example. And then SUKL, if there is a change, then SUKL asks the marketing authorization holder if he agrees reimbursement is granting. If it doesn't agree, there is a negative decision. And all the products are intended to be used only in specialized centers, so this is not valid for, or not valid for RX drugs, but we don't see it in orphan designation. As I said, the procedure should be fast, and at the end I will show you it's maybe not that fast. But basically this picture is maybe one of the best you can have to understand the process. It seems to be complicated, but it's not that much complicated compared to the other procedures. So basically, SUKL has 110 days to issue the first assessment report. Then there is 15 days for the participants to have any comments or anything which they can say they want to say for the assessment of SUKL. Then there is second assessment report being issued by SUKL. And during these times, the marketing authorization holder, in most cases, is dealing with payers to agree on the budget and to agree on some risk-sharing scheme. It can be outcome-based, but I think there are only 3, 4, 5 cases out of all drugs in the Czech Republic. But mostly it is financial discounts or paybacks or these types of agreements. Then after that, the committee is taking the decision, and this should be done in 30 days, and then there is a decision by SUKL. This all, including also the suspension of procedure, which is needed for dealing with the payers mostly, should be like 275 days, but I made an analysis and I looked at the cases since 2022 with already decisions in place, and the reality was like 3, 5, 6 days. This is the average. And the participants are the patient organizations, medical society, marketing authorization holder, and payers. I think the thing why it is quite slow is because the societal perspective is included in the assessment, and it's not easy to get the data, so SUKL asks patients, SUKL asks medical society, SUKL asks our national statistic office for health, and they also ask payers for the data, so it takes time. After the decision, if it is positive and the costs are exceeded or are more than was planned in the budgeting analysis, then the marketing authorization holder needs to pay for that. And also there can be initiation of review of maximum price on request of payers, and earliest 1 year there can be a reassessment, and it can be because the budget impact is higher, or there is a new approach, new therapeutic guideline or new treatment available, or the efficacy and safety of the product is not what it was expected. In case of negative decision, you can resubmit only after 6 months. And if the reimbursement is cancelled, then payers have to fund the treatment which is instead of the one which was cancelled. But basically, it's much cheaper therapies usually, so it's not that big deal. Now there is a pending amendment, and it should be valid maybe from 1st of January 2025, because the amendment is connected also with the joint HTA. And now it should be in the parliament, so we will see how it goes. And this amendment, I think, will only cause that there will be even more delays in the procedure, because the medical society could ask for a suspension of the procedure, and now new information will be taken into account. So if during the procedure there is any new information, SUKL can reassess and issue a new assessment report. What is important is that it's the vital thing which is being assessed is not the budget impact, but the risk-sharing agreement between payers. And also there can be a revision or reimbursement if the prices abroad changes. So here is just a short table comparing all of the pathways possible. And you can see that only in the orphan pathway there is a societal perspective accepted. And if you compare to the other procedures, I also made the same analysis. I've taken like procedures from 2022, which were decided until yesterday. So the process is the slowest. It's not the fastest that it was planned. And it's also the only procedure where patients are included as participants and KOLs are included as participants. And basically payers have 2 votes in the committee, so they can directly influence the decision. So is it a good way or is it better than the others? I think it is, because we managed to prevent the individual reimbursement quite a lot, because all of the most of the orphans were entering the market on the individual level, and payers were not able to control it, because the law says if it is the only possibility to save the patient or if to prevent harm to the patient, then it is reimbursed. So all of these drugs were just coming to the market at full prices, and no one was able to control that. So I think this is the main issue which was tackled, and it was successful. Also, there are some like ethical things that if you have no willingness to pay threshold for orphans, then you are taking the budget for other very effective therapies. And also, if you can present the results, including societal perspective, it can also distort the market because it's not fair for all. And that's basically it, and I can give the word to Magda.
Thank you very much.
If there are any questions,
Okay.
I will be at the end, I suppose.
Yes, I hope so that we find some time. Now I have the presentation. I'm sorry. Okay, now is my presentation in Polish, po polsku. Chciałabym Państwu poprosić
I would like
o
to
następne slajdy.
Now, if I may ask for my presentation to be indicated, to be presented, I would like to basically address some challenges on the payers.
I odnieść się do kwestii związanej z tym, że w Polsce mamy wdrożone od wielu lat myślenie cost containment, czyli utrzymania kosztów.
Well, in Poland, the basic approach is cost containment. The whole Reimbursement Act is an extended legal tool with multi-levels covering reimbursement plus post-reimbursement elements, and all of that to better manage costs and manage them strictly. On the example of CLL, I would like to show you the benefit of the fixed time duration.
Możemy tym zarządzać. Poproszę następny slajd. Proszę Państwa, jeżeli popatrzymy na Polskę,
Just
slajd,
have a look at
Polska,
Poland.
Z punktu widzenia, tutaj dyskutujemy, proszę następny slajd.
Poland,
Wydatków na zdrowie,
regarding the healthcare spending, is a country with a growing expenditure, but needs are still unmet. Compared to Europe, even Czechia, we are still behind. Why is it so? Well, it's hard to measure why it is so. But definitely, it's about access to healthcare, and drugs are included here. Rare diseases are the case in point, and chronic diseases are also important because of health consequences. Existing needs can be met in different ways, including through effective therapies. And our legislation talks about the avoidance of that, so the extension of the patient's life. But we have truly breakthrough therapies. I do remember Gleevec, that was our first drug, a true breakthrough in the CLL, and we had a lot of doubts because evidence was not clear. The evidence said that we could prolong the patient's life with no consequences, and it seemed impossible. And right now, for 5 or 6 years, we see that the new therapies and the immunology therapies have been changing the face of oncologies. And with that, we can meet the patient's need. But do we have the same health outcomes? And let us move to the second issue. Okay, we can spend a lot of money, one-off, and we have two challenges. The time to progression therapies is extended, and it's not about 3 months, it's not 6 months, it's about 3, 4, 5 years that the treatment can prolong the patient's life, and there is a cumulative increase. And that's the benefit, but there are financial liabilities. And the Reimbursement Act wants to mitigate the risks, price-related risks or excessive cost risks. Here you see the increase in health expenditure between 2018 and 2023. And 14% of that is absorbed by reimbursement fund. And here we have a relative decrease. It's not about increasing the costs, but it's about containing the costs. Absolute numbers would increase, but in percentage terms, it's a decrease. But even if they are on the rise, they are the speed up of the increase is lower than in other countries. And this is because of these novel therapies. Definitely, we cannot afford all the therapies, and we need to make a choice. What is assessed? And in hematology, we have the following criteria. Look at this slide. Here you see the level of expenditure by the National Health Fund, 40% for reimbursement, but still we have managed to introduce new molecules, and we will see if the trend will stay with us for the next years. Here you see a summary, more than 180 publications, a review made by the Dutch. They measured different mechanisms used to contain costs. I will not go into details, but they just managed to review all the mechanisms, and all of them, the majority of them, exist in Poland. Supply and drug programs are the most restrictive, and this is the most important cost containment mechanisms. And this is the least present element in the system. For others, we all have them. We have them all. So the price and the volume. The volume can be managed on the side of supply and on the side of demand. So who will provide services to the patient, and then inclusion-exclusion criteria, you can manage the volume because you narrow or you extend the population covered by the therapy. We are one of the most restrictive countries in this respect in Europe, and this is because of the budget available. So, do we want to improve access to therapies which are actually effective, as it is proven by the existing drug programs? And then, who should be targeted? Through what mechanism? And that will be the question I'll try to answer in my presentation. Let's start with the expenditure by the payer in the drug program in CLL. There is an increased number of patients since 2017 with the first new molecules. We've seen an exponential growth in the number of patients. This means that the access has improved, and this is good news. We extend the program to a large group of patients who can get access to novel therapies. Price containment mechanisms help us to reduce the price of the therapy, and then there are generics who will substitute sooner than later, 10 years maximum. So this population, the therapy of this population will cost less, but even more because we will have to cover it for a long period of time. Just have a look at this journey. What happened with the introduction of new drugs? You see in green fixed term duration therapies. In CLL, we had treat to progression therapies, and this is a typical hematological or oncological therapy. We also had these FTD therapies, and we just looked for the results. So there is a shortened time of therapy and less side effects. This was the first case of the kind in Poland. The majority of these therapies is based on venetoclax. First and second line of treatment, you see both of them are in the table. You usually introduce novel drugs for patients with advanced disease, but there is no other treatment option, so third or fourth line. But then you got registration for the second and the first line. And in Poland, we did that. First it was third line, then the second line, and we ended with the first line. And the earlier you start, the larger population for treatment you get, because the group with the first line treatment is the larger one. And then the profile of the patient counts as well. For CLL, you have fit and unfit patients. So fit patients are younger and with no comorbidities. Unfit patients are older with comorbidities and higher risk of death, plus genes and their mutations. The introduction of those therapies is good. You can use them for both fit and unfit groups, and FTD therapies are actually effective independently of the outcomes forecast. So the payer will ask, who should I finance? In terms of unmet needs, unfit population should be treated first. And that's the way we do it for reimbursement. Myself, I'm a reflexive thinker, and I ask myself, is it better to offer the drug to all the population in order to secure everyone, and then just change the drugs at the next lines of treatment, or just choose the target group because we cannot afford everything? I believe that every time you need to make a calculation, the whole budget for the scenario where the whole population is covered with hospital stays, side effects, and so on and so forth. Often in Poland, such adverse effects are not included in the calculations in Poland, but there are some countries who do that.
But the most important aspect is the question of effects. And here you can see the fixed time duration therapies, the triangles, but also how long is the life to progression and survival. You can see that the percentage is greater the shorter the therapy. Well, that's obvious that with time the effects will decline, but after 80 months relatively good effects are maintained. So those therapies give rise to the question of whether we should differentiate it by efficacy or by the cost. And another question which the payer should always pose: should we provide patients with a lot of options or just selected options? From the perspective of optimizing effects, we should give a larger number of options, because we do not know to which the patient will respond best. But we can also stimulate certain initial stages of treatment. What became apparent after a long-term analysis from other countries? We've got examples from Canada and the US. It turned out that the use of fixed-time durations leads to a significant reduction of costs with similar therapeutic effects. After taking into account all costs, this allows for cost optimization. So changing the timeline of treatment, start introducing treatment in first line for both fit and unfit populations allows for savings with similar effects. Can we afford it? That's a different question. Here we have a summary of costs in the second year of treatment of CLL in the US, depending on which costs which were taken into account in subsequent lines of treatment. When it comes to the US, it's cheaper. When it comes to the Canadian example, they also measured it in a longer time perspective. Over time, it turned out that those therapies also lead to reducing the costs when taking all costs into account. So not just taking into account the cost of the drug. This is something which we tend to do. We just focus on the cost of the substance itself and not on the indirect costs. This is something which in the calculation of FTD therapies should be taken into account. This with FTDs, we would be able to achieve reduction of other costs, indirect costs. So the main question with regards to optimizing spending in Poland, first of all, how the number of patients will increase. So will we consent to expanding the reimbursement indications, or do we keep the current population? Should we also introduce the treatment as first or second line treatment? Unfortunately, I have to say that for the payer, this perspective can be even 10 years if they were to have an overall look on the situation. So to sum up, what we are trying to promote from the perspective of costs of treating patients and increasing the availability of the latest therapies while having in mind optimizing of long-term spending and measuring results. As on the example of other countries, it's time to introduce in Poland to focus not just on the budget impact of just the drug costs, but also include indirect costs and other costs, and also measuring effects. We started with measuring the timeline for 2 years. In oncology, it's always in place. We hope that in hematology, basically all those indications are rare diseases. With the current level of digitizations, we will be able to measure not just the level of care, but also the economic efficiency of the healthcare system. Thank you. Ladies and gentlemen, we have a few more minutes, 8 to be precise. Do we have any questions? Thank you. Zuzanna Piątka. I am a representative of the Bezpestkowe Foundation, so Seedless Foundation.
We are helping women with rare disease called MRKH syndrome. And you can read about it in our brochure that everyone got today. And I've got a question about the path that you were talking about. Is it only for the medication, or is there a way to include also medical tools? I'm asking because we, in our foundation, a lot of women that have this disease there, I don't think that they should use any medication, but they need some tools, for example, dilators for the vaginas. And the thing is that they are coming to us because a lot of them doesn't have money to get them, and a lot of doctors says that they should contact with us to get the set. And this is a thing that you cannot buy in a pharmacy shop in Poland, but you can buy it in a sex shop, and a lot of doctors recommend going there or to us. And that's why I'm asking this question, because the path that you were talking about was pretty impressive to me. And yeah, thank you.
Yeah, it's a very simple answer, because as I mentioned on the slide, it's only for the EMA designation of orphan. So currently we are not assessing the medical devices in this way. Okay. So I think it would not be like applicable. But also in the Czech Republic, we have been now updating how medical devices enter the market. And because the process now, it takes also like 1.5 or 2 years. And it basically, you have to ask in the first year, and if you have a decision even in March, for example, then you are reimbursed from 1 year later. So this is one year and 3 quarters. Okay. Yeah, but now they are trying to speed up the process, and yeah, and so for these tools or medical devices, it should be better. I don't know how it works in Poland, or a bit. I know how it works in Poland. It's just not working on one case.
Maybe tomorrow is for medical devices.
Yeah, but no, unfortunately, it's only for drugs.
Okay,
currently.
Thank you.
Tutaj z przodu Marcin.
Marcin Czech, so there will be a question from Czech to Czech. 3 very short questions. First of all, congratulations on the regulation. I was listening to your Vice Minister, Mr. Dworacek, in Polish Economic Forum about the issues associated with this new mechanism. First one is, in the MCDA you presented, do you have weights associated with each point? Okay, first one done. The second one, is it obligatory for the companies to, so is there a cutoff point on budget impact analysis, and after amendment of your law, capping mechanism will be obligatory for payback? So
no, there is no obligatory payback, and there's no threshold for budget impact. But it has to be within the public interest. So this means you have to ensure quality care, but with sustainable financing. And this is on the individual assessment of payers mainly, and now on the committee, on the orphan committee.
So it's not, I've misunderstood it clearly, that if your budget impact now exceeds what is declared in the documents from the company, they cover the rest. It's
the company covers the rest. Yes, that's in the law. But there is no obligation to, for example, if it is 5 million euros, if it's
there is no threshold, you mean?
No, no threshold.
Yeah, I understand.
But if it exceeds the budget impact presented by the company or presented by SUKL, then the marketing authorization holder has to pay for that. But now it will be changed that it will be based only on the risk-sharing agreement with payers.
But you can have capping mechanism, which will work similarly.
Yes.
Most probably. Yes. Obligatory or not?
It's not obligatory. Okay. But so most usual way of risk sharing.
And the last one, if you have you showed the committee and representation of the committee, do you see the tendency of clinical professionals and patients' organizations voting for the solution, and payers and Ministry of Health voting against?
This is a secret. No one knows.
Nobody knows. Okay, because thank you very much for this effective
because it's not public, and the voting is done secretly, so you cannot find it anywhere, and it's behind the doors, so closed doors. So
thank you very much. It was very informative and very valuable. Thank you.
Any questions? I have question. Okay, my question is, because you mentioned that there's some probably these inequalities when you assess associated cost. My question is, for example, you have the disease that the survival without treatment is, for example, 2 years, yes, and then you introduce the drug, improve then how you assess the societal cost, how the data put it, then what is the impact that with drug and without drug? This is my question. How you assess the impact on the decision?
Yeah, thanks. There are two possibilities to do it. First is to use the macroeconomic data. So basically, you just calculate how much is 1 hour of working of the patient worth to the state,
Okay.
based on the GDP, and there are some like normal working times, and this is the methodology the Czech Pharmacoeconomic Society did. And the second thing is we are creating questionnaires, sort of questionnaires. So how much do they consume from state? Because we don't have very specific data from the Czech Statistical Office or from the ministries, because it's not, you cannot like ask for a patient number, and you don't have the diagnosis included, so you don't know. So you just ask the patients, then evaluate the questionnaire, and you state, okay, 1 year of life of these patients costs this much for transportation, this much for subsidies, this much for invalidity subsidies, and so on.
And my question is that surveys are based on the representatives, but the patients' organization, or just who is making the surveys to collect cost data?
It's mainly the pharma companies, and they are working with patient organizations, or they are trying to reach the patients on their own. And it's very difficult because it's rare disease, so there are already not enough patients.
But it not means that it's opinion based, but that you are trying based on surveys.
Yes, surveys.
Okay.
And basically, you are right that if you have, for example, children, and you prolong the life by 15 years, then the societal perspective results in much worse ICER than the payer perspective only. And the same with the elderly, because usually it is not that they are like healthy, they still consume the societal subsidies, but they live longer. So unfortunately, the result is worse.